Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're going to have a talk on pain, its causes, and its management from Dr. Katie Greiner. She is an optometrist providing patient care at Northeast Ohio Eye Surgeons and ODMD Group, where her clinical focus is contact lenses, especially the specialty and hard to fit contact lenses, as well as anterior segment care. She's very active in the optometric community, serving as a current board member for the Ohio Optometric Association as a trustee, and has had many past positions with the Ohio Optometric Association. In 2024, she was bestowed the Early Professional Achievement Award from the Ohio State College of Optometry. We've had her at live meetings, we've had her for webinars. She does a terrific job, a great new voice, and something terrific to listen to. So, for that, Katie, thanks so much for being here, and take it away, please.
Thank you, Greg and Joe. I am very happy to be here. I'm excited to talk to you guys on a summer night, and we're going to make it fun and lighthearted. I had a lot of iced coffee an hour ago, so I am raring to go. These are my financial disclosures that have been mitigated, and I do not claim any superiority if I do mention any products this evening. All right, so many things rhyme with the word pain. So I've got a theme here. Pain, pain, go away, come again another day. So just a quick outline for all of you of what we're going to be covering. We're going to go into some basics on pain. I think it's a good reminder, maybe back to your biochemistry days, how it affects, the systemics, the eye specifics, our general health, our activities of daily living, mental health, very important topic these days, and always, how we can measure pain realistically in our world, how we can communicate with our patients around pain, set the proper expectations, and then manage them. How long do we think this is going to last? What are the limits that we have in our practices for pain relief? And the first section, this is kind of in two parts that we're combining for the evening. We're going to start with anterior segment disease and things that you can probably, as an optometrist, really easily manage. And in the second half of the presentation, we'll go into things that we might need more advanced care for, specialist referrals, lab work, those kinds of things. And then really at the bottom of this comes down to, building that doctor-patient relationship. And really your most satisfied patients are the ones that you help make feel better, which is what we're all here to do, help our patients. So we're going to kick it off with a poll question right away from the beginning, kind of a little lighthearted. It doesn't have to do with hamburgers, though. So my first question is, what is pain? Is it something you need 2 credits for in Michigan every CE cycle? Is it a Friday at 5 o'clock add-on case? It is a very broadly defined in terms of the patient's tolerance to it, or very broad in its presentation in your chair, or all of the above.
All right, the question is open. You did get a shout out from someone from ADA. Is it Ada, Michigan? So you got a shout out when you mentioned Michigan. So
Wonderful, yeah. So if you think A is part of the question, you're going to like me tonight for those credits.
So the answers are rolling in. Obviously, at this point, there won't be too many questions. And we got a nice little trend here going with people. Remember, this is part of the synchronous. So try and find that polling, which is on your right-hand side, second one down. It says polls. You can click on it. And then once you click on it, you'll see it. And you can put your answers. That makes it the synchronous part for helping with the accreditation part of this. So with that said, I think the trend has been set here. We have 2% for A, 3% for B. I think you got some people out here feeling a little pain on that very broad term as 21%. You've got very broad presentation in your chair at 7%, but 66% with all of the above.
Okay, well, they are correct. That's 66% E, definitely all the above. So we're going to talk through all the pain types of situations that can land in your chair. But first, let's make sure we define pain. And so as we define pain here, it in the dictionary, unpleasant bodily sensations, sensations that cause mild to severe physical discomfort, can cause emotional distress from this injury or disease. It could even be induced by a harmful, noxious, unpleasant stimulus at naked nerve endings, causing discomfort from things like pricking, throbbing, aching. But also, I think my main definition of pain is childbirth. If you haven't experienced that, you might not be able to agree with me. And what I hear is also terrible right now is razor throat COVID. I feel like I'm jinxing myself saying that one out loud, but I hear that one's pretty painful as well. I always like to understand the origin of the words, especially, a lot of our training has Latin roots. This one in pain from Middle English, also Latin and Greek, means payment or penalty, dating all the way back to the 14th century. Pain comes in so many forms, and you all know this from your experience of your own pain or with patient care. Sharp, dull, persistent, fleeting, acute, chronic, right? Could we get any more opposites going on there? Or is it really even pain? Do we define it properly when people are talking about it? We all have different ways of describing pain and experiencing pain. There are many types of pain. Nociceptive pain, which is damaging tissue. It's acute pain. Neuropathic pain, where we have nerve dysfunctions, things that are affecting spinal cord, brain, peripheral nervous system. These can have different feelings like a burning, a shooting, a stabbing. I definitely want to make sure we cover corneal pain without stain. That's a very popular phrase you'll hear from people on the podium, where these patients look good, but they're experiencing pain. Is it from headaches or depression or fibromyalgia? And then, of course, inflammatory pain with your immune system's response. With that type of pain, you typically get swelling, redness, and definitely an increased sensitivity. And experiencing pain is really there's a pathway to that. So our nervous system thinks that your body's injured or in danger of getting injured. We learn pain. We learn pain from a very young age. We look at something sharp or hot and say, if I'm going to touch that, it's not going to feel good. And that's, sometimes I remember my mom saying, you're never going to get this until you do it yourself and you experience that. So maybe tough parenting, but it made me stronger in the end. And we train our kids very young to avoid things that can cause pain. So your brain says something is wrong. I should do something about it. And we don't become aware of that pain until it goes to our brain, which in the transmission process is very quick. Luckily, there's a good feedback loop to say, okay, stop doing that. It's painful. So here's our neurotransmitters, taking us back to biochemistry and boards questions. But when we're injured, these special pain receptors at the injury site release these neurotransmitters and quickly send that signal to the brain. This travels along the nerves, the spinal cord, and then ultimately to the brain. Your brain perceives that, processes it, and decides what's the next step. Usually that next step is get away, flight, get away from that source. Also at that time, immediately your brain can start releasing endorphins to help deal with the pain and even trigger your immune response to start healing very quickly. Chronic pain is a totally different science now. Pain is an alarm. It's telling us sirens, this is a problem, we need to be safe. But when pain signals keep firing, even after someone has technically healed, this is when pain can become chronic. So this is when there's actual changes done to our nervous system biologically that make someone much more sensitive to pain. And these stimuli can become even more heightened, so you can feel pain even more quickly. And when it happens, it can be intense and it can last longer. And we know in society, chronic pain is a major issue. There are specialists that's what they devote their career to, is taking care of people with chronic pain. We're talking hundreds of billions of dollars in the industry. And there's so many factors that will be unique to each person. So your biology can be how your differences in our biology can be how we understand and comprehend pain. Past experiences, like we talked about, even as a child, forms of chronic pain can change the way that you experience pain. Emotions and mental health, if you're not sleeping well, you're over-caffeinated, under-caffeinated, anxiety, stress, all those things can affect your level of pain tolerance and definitely the environment you're in. So as you already know, everyone's pain feels different, and it's really hard to measure this objectively. It's very subjective, and we're going to talk about that tonight. And most definitely, not one single treatment works for everyone. I wish that, 2 Tylenol would work for everybody, but definitely that's not the case. And pain management obviously depends on the kind of pain that's being experienced by the patient and exactly what's causing it. And oftentimes we have to be creative in that. We have to have combinations of treatments to get to a better result for comfort for our patients. So just throwing out a few numbers, I did mention that this is a multi-billion-dollar industry, including our medical treatments, disability, lost productivity from people in chronic pain, up to $635 billion annually. And 1 in 5 adults, that's a huge number, experience chronic pain. I can think about my schedule of patients I just saw and how many of them were, holding their back or requesting a pillow, sitting in the chair. I do see a little more of an elderly population, but definitely you can see the ones that are in chronic pain in your chair. And it tends to be higher in those, 65 and older. Our most common chronic pain conditions are typically low back pain and migraine, and those are the leading causes of disability around the world. Again, most common medical complaints of older Americans is chronic pain. And, some of these things can definitely manifest in the eyes and in your chair. So things with joint pain with your rheumatoid patients, that can also show up as different conditions in the eye, like a uveitis or a scleritis. We're going to talk about those things tonight. So that's on general pain, but what about eye pain, right? That's really the big piece of what we're here for tonight is eye pain. And superficial structures can have so many different feelings. We know that our cornea is extremely sensitive. Itching, we're going to talk about that. Like, is that really pain? Maybe to your patient it is. Burning, a shooting pain, a stabbing pain. Deeper structures tend to feel these deeper aching, soreness, throbbing, kind of like someone squeezing their eye. So we're going to talk through that as well. And then this is your reminder, again, a board's reminder of how our neural pathway works for ocular surface pain. So the corneal receptors on the surface of the eye, we're at the first division of the trigeminal nerve. So remember, that's 3 different divisions, and the first one is your ophthalmic nerve. That will then travel, signals there will travel to your trigeminal ganglion and then to the trigeminal nucleus. On the way to the somatosensory cortex, these neurons will synapse in the contralateral thalamus. So I'm going to show you a quick anatomy picture of that to kind of reorient you to our anatomy there. Some axons from the trigeminal nucleus will go to the brain so that in response to eye pain, we'll start to lacrimate. So we'll get watery eyes, we'll start to blink using our facial motor nucleus. So we know the eye reacts very quickly to discomfort or pain, and we're lucky it does that. That mechanism is to water and to blink or close the eye. So that feedback is through lacrimal gland, goblet cells, meibomian glands. Then they adjust our secretions to wet the eye and hopefully relieve ourselves of discomfort. So here's a lovely stick going right into our guy's eye here, hitting that ophthalmic nerve into your trigeminal ganglion and then into the nucleus. All right, so that, Greg's going to tee us up for our second poll question of the night.
Okay, we
All
can
right.
do that.
The eyeball and the periocular tissue have very dense nerve innervation except for the A, cornea, B, conjunctiva, C, lens, D, retina. All right, we're getting crazy. E is B and C, and F is choice C and D. So E is, do you think it's conjunctiva, lens, or F, do you think it's lens and retina?
Katie, a comment came in about somebody who has a friend in neuroscience who used to say pain and inflammation are the same thing. What are your comments on that?
I like that comment. I think that person might even be smarter than me, so I'm going to say they're probably right. But yeah, I mean, I think inflammation can cause pain. Even doing this lecture, I don't pose to be a pain expert, but I unfortunately have a mother with chronic back pain, and as I've gone to appointments with her to help her manage this chronic back pain, that's been a topic, is it's inflammation. I mean, that's what keeps coming up, Joe. So I can't say that that's wrong. I kind of like that. I'll add that to my next pain lecture.
Yeah, I do some stuff in functional, and there's a lot of functional docs, that are dealing with arthritis, injury, infection, autoimmune, neuropathic pain, and that's kind of the root cause of inflammation. But it's not, I wouldn't say everything. You can maybe link it back, like neuropathic pain, the phantom limb. That's really not going to be inflammation. Fibromyalgia. Maybe a
Yeah,
lot
we don't know, right?
peripheral, maybe inflammation, but I don't think it really is leaning in there. I think at one time we might have been able to say the root cause was inflammation, but I think now we understand it. It's probably a little bit beyond just all inflammation. So. All right. And then one comment I'm going to make is pain is not always negative out there. We all have friends that said, oh, I have a shoulder problem. They went in and maybe found a little tumor in their shoulder. It was pressing against something and that caused them to go to the doctor. So we always think of pain as in a sense of being negative, but it's not always negative. It could be life-saving
Life
if it gets
saving.
you to go to the doctor. So,
Yeah,
all
no, I
right.
like that example. It's your body's way of telling you something isn't quite right.
All right, so let's see here. We've got 1% going cornea. We got 2% going conjunctiva, 23% going lens, 1% going retina. B and C is 7%. The winner was F at C and D at 65%.
Well, this is just the smartest group. I love it. So you are correct. We're going to talk about that here in this slide. So let's talk about eye pain. Let's dig into the eye. The eyes and the periocular tissue are very densely innervated with nerves, but the lens and the retina are not. So you don't typically hear someone say that their lens or their retina is in pain. It definitely is more of those superficial structures that we're going to dive into tonight. The cornea has the highest density of sensory neurons in the entire body. You can believe that because if you've ever been poked in the eye, you know how bad that can hurt. And we have that protective defensive mechanism where we are sensitive on our cornea to many things like mechanical injuries, temperature sensitivities, chemical irritants, chopping an onion. All of those things can cause us discomfort of some sort, which some patients may call pain. To remind you of the anatomy, our corneal nerve endings lose that myelinated sheath about 1 millimeter away from the limbus, and then they come in and enter the cornea. You can see it in this photo here as well, from the periphery in a radial fashion, most concentrated at the 3 and 9 o'clock hours. And they create this nerve plexus in the anterior stroma that then penetrates into the epithelial surface, and that makes the nerves very susceptible and sensitive to any exposures from the outside. These sensory nerve fibers are involved in the transferring of pain to the posterior segment, are not as understood as we know from the cornea. So there is definitely a different pathway that's still being figured out, but we do think that there are some polymodal receptors that are involved in pain related to our uveal tract. But the posterior segment, we don't tend to have that pain sensation. So how the heck do we have patients measure their pain? I did a lot of work looking at different scales, and I have this reference for all of you at the end, but I felt like this one was a really good description. It's quite wordy, and I think it's not always as practical in clinic. I'm going to skip forward to my next slide real quick and show you that's probably more practical, right? You've all seen that in emergency room or in urgent care. But I do want to talk through this because you guys know, I'll ask someone their level of pain, and I'll say, okay, if 10 is like getting your legs sawed off with no anesthesia, and they look at me and they're like, oh, yeah, it's definitely that, right? Like patients really need good descriptions, and you need to help them understand what 0 to 10 is. This scale is recommended for someone over the age of 9. Not all patients will understand it still, but it is nice. Like I work in a larger group practice, and so we really do try to standardize this conversation. So if my colleague sees the patient and a day after me and I had them on an 8 and the next day they're a 4, we want to make sure we're talking the same pain language. So I'm not going to read every slide verbatim to you, but I think this one's important. So 0 is no pain. 1 is mild, barely noticeable pain. 2, minor pain, but it is annoying. 3 is noticeable pain that's now starting to become distracting to the patient. 4 is moderate, but it can be ignored if you're busy. So if you're encompassed in an activity, you might not notice it as much. Once we get to that mid-level of 5, moderately strong, you can ignore it, but not for very long. So it keeps coming and going in waves at where you notice it again. 6, strong pain, moderately strong, makes it hard for you to concentrate, and actually you're starting to give up activities that you normally would want to be able to do and enjoy. 7, strong pain keeps you from normal activities. Now you're staying at home, you're avoiding daily life. 8, strong pain, can't do anything. So now you're laying in bed. 9, excruciating pain where you can't even carry on a conversation. You have to think that's pretty bad. And 10, again, having your leg sawed off without anesthesia. That's pretty graphic, but that's where we would, rate a 10 when we talk to our patients in clinic. But again, you can make it a lot easier and have them point to it and show no pain to the worst pain ever. And that scale tends in studies to be the one that patients relate to and like the most. There's a huge patient-doctor relationship when it comes to pain and helping make them feel better. Our job is to relieve that and make them more comfortable. But that's also doing that within your scope of practice. Just like your CE virtually is different across states, so are ways that we can manage pain. So this is not an opioid talk this evening. It is just ways that we manage different pain in the clinic with our general tools and things that we've learned in school. You probably get the question all the time, no patient, you cannot take the anesthetic home with you or get a prescription for it, because that is like one of the best pain relievers for our anterior issues, and common question that I get in the clinics. And as always, we should be watching for drug seekers. There are definitely some signs with patients that are seeking, and we need to be careful when their symptoms don't correlate with what they look like in your chair. If they're asking for pain medications for things that would never warrant the use of a pain medication, oh, I have a little sty, can I have, oxy for that? Obviously, that's a red flag. I've had patients come in talking about other pain medications they're on, and doctors they know that will prescribe them for them. Or if they come straight out and say, hey, I have this problem, I need this drug. They're telling you what controlled substance they need. Or if you've barely come in the room and the first thing they're asking you is for a prescription substance that you're not going to prescribe for that condition. So these can be uncomfortable conversations, and ones that you really need to nip in the bud and say, either that's not in my scope of practice, or it really doesn't warrant that, and I'm so sorry, I'm not the right doctor to prescribe that for you. I don't think it warrants that. So you really need to have the confidence to shut those patients down so they don't keep coming back for asking for that again and again. We're on a roll with poll questions. We're getting them done early here, Greg. We're on number 3. This might be more of an opinion from your speaker, but I think, to me, I want to point out as we go through this talk what I think is the most important part to figuring out the cause of your patient's pain. Is it getting a thorough patient history? Is it checking corneal sensitivity testing? Is it getting the patient dilated? Or is it a red cap desaturation test? Tuesday summer night. I'm trying not to make this too difficult.
Katie, are you going to cover acute and chronic, the difference in acute pain and chronic pain?
We kind of did that a little in just the, biology and behind it and how it develops. Not probably in too much detail tonight on that. I think some of the conditions we'll talk about, like a acute iritis versus a chronic iritis, but not anything in extreme depth.
While the poll was running here, I do a pain lecture, and this was taught to me by a pharmacist that does chronic pain management. And you went over that scale so great, and it's good to use, and you don't have to have them in there. You can just Google it on your computer and show it to a patient. You don't have to have them hanging in your office if you want to use a pain scale, and for those in the audience that are out there listening. But when it comes to chronic pain and acute pain, when you go into a chronic pain management, as Katie listed, there's so many reasons why that can happen, and her patients are in her chair. they're not trying to get the patient to zero pain. They're trying to just so that they can live their daily function. So they might have pain, but they're able to go to Disney. They're able to go to work. They're able to drive a car. They're able to sit in that chair and not be uncomfortable, but still have pain. So there's a difference between chronic pain and acute pain management. Acute pain, we're trying to get them down to zero. And probably what we'll see tonight with Katie's presentation is most of our patients are going to come in with acute pain. So what we're trying to do is get them to zero, or as close to zero as possible for those 3 or 4 days or a week that we're treating them. So chronic pain is different. You're just trying to get them to do their everyday function, not gorking them out. But we might want to gork them out with eye pain because they might want to be able to sleep and get through that. So,
And I think when we talk about that, like your chronic pain patients, you could have your rheumatoid patients that are being managed for chronic pain, but the acute side of it could be the flare ups that they have in their eyes that we're treating to get to a zero in their eye, but they're still going to have the bodily, systemic chronic pain. So that's a good point, Greg.
perfect. All right, your polling question. I have it displayed. I have A at 96%, and then B, C, and D are 3, 1, and 0. So,
Hey, thank you guys. Okay, very good. Getting through a patient history. By far, to me, this is the most important thing. I train our staff and our student externs heavily on patient history, but ultimately, I still go in and make sure I cover even more questions than they asked. Here's a big list. It's in my notes, but when did it start? Has it gotten better or worse? Sensitivity to light. Describe your pain. Where in the eye does it hurt? They point all over the place, but sometimes that can be helpful. Certain eye movements make it worse. Have you had this before? Did you have an injury? Do you wear contact lenses? That's a huge one. Vision changes, discharge, headache. What's your systemic history? There's that word we're going to hear many times tonight, inflammation. What makes it feel better? Is there anything that makes it feel worse? So getting as much detail as you can is going to be, I think, 75 to 90% of the work, and then the rest of it is your exam. So a couple things that are really important in history, and I just grabbed this from actually ophthalmology, one of their handbooks here. Some major things we should be asking. Contact lens, that can cause a variety of problems and some pretty severe issues that will cause pain. If they have decreased vision with pain, there are some much more severe issues that can come from that, like your optic neuritis, angle closure, scleritis. We're going to talk about those tonight. Foreign body sensation definitely can cause discomfort, maybe some pain, but really, those things are pretty easily fixed, and we can probably get them to a zero with the right treatment. Headache is tough, right, you guys? Like you hear headache in your chair, and it can be so many things. That one's a really hard one. Photophobia usually has a pretty good pathway to, several things that we could treat, although again, headache can be part of a photophobia issue as well. Stabbing and boring pain, more of your scleritis, also headache there. And then when we hear those inflammatory autoimmune conditions, we're definitely honing in on a scleritis, a uveitis, optic neuritis, those types of things. So obviously we said that the patient history is important, but your thorough patient exam is also important. It is so crucial, and I say this to students all the time. We need to get a view of the patient's whole body. I already said to Greg, I get patients in my chair that are slumped over, trying to prop themselves up on a pillow. That gives me an idea right away. Are they arthritic? Are they sick? Trash can nearby, you probably can guess where I'm going with that. I've walked into a room with an angle closure and they're throwing up. Like, that's my red flag. Okay, we probably have a pressure of 60 today. Look at their face. Do they look uncomfortable? What's their pain level? Are they grimacing, gritting their teeth? How many times have you missed a swollen eyelid because you come in that room and you just quick throw that slit lamp in front of them and you're looking at the cornea and the eyelid is, out of the picture. So look at your patients before you throw that slit lamp in front of them. When they move their eyes, do they have pain? That's a huge one for us to note. Look at the things like look for an APD in our optic neuritis patients. Things on their lids and lashes, if it's just covered in crust and debris, that can actually cause discomfort, which they can interpret as pain. And then obviously, again, your cons, your cornea, your anterior chamber, your iris, your vitreous, your optic nerve. Note, I did not say lens and retina because those don't cause pain, but you should still look at those. on your physical examination when they're presenting with eye pain, things like injection of the conch will kind of start guiding you on some different differentials. Eyelid swelling, we know to go to different things like your cellulitis issues. If they have high IOP, are we worried about an angle closure? Do they have pain on eye movement? Then we get more nervous about an optic neuritis, an orbital cellulitis. If we see an APD, then we're thinking with pain, we're thinking more optic neuritis. And then using fluorescein and staining, we're thinking, okay, there's a keratitis or an abrasion of some sort here. So pretty common sense pathways when you break it down this way. So a lot of my talk is structured around following this lovely chart. I think this is a really good way, and it's a great way to teach students, how we're thinking through differentials. So for this first half that we're talking through right now, we're going to be more towards the right side. And I just think this is a great way to talk through pain. So this is also in your slides that I prepared in advance for you. But if there's corneal uptake or stain, yes, we're going to follow along. He said I can use my pointer. So yes, then maybe we're thinking something like dendritic or herpetic. If there's a linear or geographic mark, then maybe it's more of an abrasion. Punctate, we're thinking SPK. Following that pathway, we've got already several problems here. And going the other way, if we have no staining and there's not elevated eye pressure, then we're going to say, okay, is there decreased visual acuity? No, we're going to do the scarier stuff a little bit later. Decreased visual acuity? No. Is there hyperemia? Yes. Maybe conjunctivitis? No hyperemia, but there is some photophobia. Then we might be going towards uveitis or keratitis, or if there's not photophobia, which, sometimes with dry eye there can be, but, maybe your differential is dry eye. So we're going to work through this right side of the chart here in the next few minutes. Remember, common things are common, okay? I try to make sure my students realize that too. I want them to know all the things, but when you hear hoofbeats, we should think of horses, not zebras, right? Have you heard that phrase before? One of our professors at Ohio State, Dr. Early, said that in all of his lectures. So we've got to go with our common sense first and then start thinking of those unique things if the common sense doesn't make sense. So where am I going with that? I live in Ohio. We are one of the allergy capitals of the country. Patients come in, they call and tell my phone center, I am in so much pain. I have to get in to see her, even though she's overbooked by 10 patients. And what is it? It's allergies. They have redness, itchy, maybe sore, watery, swollen, painful, maybe not. Again, we all interpret things differently, and I can treat them pretty easily. Antihistamines, eye drops, mast cell stabilizers, combos, take your Zyrtec, scrub your lids, cool compresses, etc. So remember, common things are common. Start with the easy stuff and kind of work your way through that tree, because definitely it could be something else. It could be an infection. It could be an injury. It could be a foreign body. Acynopia, right? That's so common. That is definitely interpreted as pain, eye strain. And there's so many reasons for that. Are they overcorrected? Are they undercorrected? Are they presbyopic, but they're ignoring their symptoms until they come into you with pain? Do they have a BV problem? Are they not using enough light? Do they have a lot of anxiety, headaches? I love to practice the 20-20-20 rule, where I have them take a 20-second break, looking 20 feet away every 20 minutes. Realistic, probably not, but I try to harp on that. And then Harmon's distance, I work with a pediatric specialist, and she loves to talk about we should always have the distance from our chin to our elbow from our reading material to make things more comfortable. So acynopia definitely can come into your clinic as pain. But what's real pain? This one's real pain, you guys. Corneal trauma. If we have a patient that says, hey, I had an injury, then yes, this is definitely a cause for concern. In the upper right picture, this is not a surgical PI. They did not have narrow angles, but in fact, they had blunt trauma. Metal on metal should always be a major red flag. If they're using something metal to bang onto something metal, that can have really high velocity into the eye. Look for a shallow chamber. Look for an intraocular foreign body. Look at the iris. Look at the lens. Sometimes it dings right through the lens and you'll see already a cataract forming. We'll talk about a Seidel sign. And, Greg, you're in a rural area, so I've practiced before in more of a rural area, and I've actually had to say, okay, I'm going to get you on an oral antibiotic. I think you have an interocular foreign body, but I can't get you to the nearest, scan for hours. So I try to get them on something quickly if I can. But if they're close to an ER, just get them there. They need a B scan. Here you can see there's a foreign body, but really get them to an emergency room with a blunt trauma, and they can get a CT scan, and it can pick concerns up like that pretty quickly. Sidel sign, definitely important to be able to look at in practice. This is where you'll take a fluorescein strip and kind of gently wipe it across the surface where you think the injury is at. And a positive Sidel will start looking like a little waterfall. And you have to do it quite a few times. It's not always obvious at first, but if you see a narrow chamber, a shallow chamber, most definitely this should be one of the first things you're doing, looking for that site of injury. And that could be, not only trauma, that could be, in a post-surgical leak, a bleb, any form of perforation that could have happened to the eye. These patients need to be closed quickly, so covered with a bandage lens, antibiotic coverage, and then referred out. Oftentimes our cornea specialists will just glue these spots now. Glue has become a really wonderful way to treat the eye without leaving permanent, scars and as many issues. But penetrating injury is very scary in your chair.
Let me make a comment to the audience here regarding doing a Sidell's, because I see the students and residents, and a lot of times they'll put a drop of fluorescent, put the patient behind, and then put the patient behind the microscope. And you literally have to have your sodium fluorescein strip wet and think where the leak is and paint it. And you have to be behind with your cobalt filter, hopefully Ratten filter, and maybe you'll see it leaky because it's a fast leak. By the time you put it in, put the patient back here, you're going to miss it. So it's
Totally.
basically behind the slit lamp and you're painting that. So if the clinical pearl I want to point out is you're painting the area that you think is leaking.
And
I
the and the
paint. Yes, Joe.
and the two clinical pearls, just to add on, there's also the pressure Sidel test, because a penetrating injury can self-seal and you may not get it. So you put a little pressure on the eye, then it starts to leak. So you got a pressure Sidel. If you really think that it has penetrated, don't just go negative Sidel. Give it a little pressure and see if it's a self-sealing thing, because it could mean there's something in there brewing an endophthalmitis. And also remember, not all penetrating injuries go through the cornea. They can go through the sclera.
They can go through the sides. And yeah, I mean, these are definitely urgent. And I think all your comments on Sidel are spot on. And I mean, the amazing fast traumatic cataract that can form in these, like sometimes you won't even see where it entered, but you will see that they already have developed a traumatic cataract, which is pretty crazy. Chemical trauma that involves immediate flushing. They need sterile water or saline. If they call in, that's the first thing we say on the phone is make sure you flush your eye before you come in. Let's get as much rinsing as we can. I am a huge fan of keeping pH paper in the office. We're going to talk about that on the next slide. And we will irrigate the heck out of these patients in the office until we get that pH strip to show us a neutral 7. Aggressive lubrication will be needed after this type of chemical injury. They're going to need an antibiotic, usually a steroid. We'll talk about the healing properties of vitamin C and doxycycline. Cycling these patients can bring some relief and comfort, but chemicals can be very severe. It can, really result in some major issues of significant corneal opacification. And how many of you have seen a thermal injury with all of the new toys that us ladies use on our hair, from curling irons to straighteners to crimpers to wavers? All those things are coming back with a vengeance. And I have seen all too many patients, one being my cousin, drop a heated device directly onto the cornea. This is awful. Luckily, they heal very well. Similar treatment to chemical. In these patients, you may need to use a BSCL. We'll talk about pressure patching, but these can cause some pretty significant damage in corneal thinning, melting, some blepharon. So here's your pH strips. If you remember this from 7th grade science class, getting the litmus paper is so cheap. I mean, this is a couple bucks on Amazon. You don't have to use one that's specifically made for eyeballs. It's just standard litmus paper. 0 to 14, remember 7 is your neutral, 7 is acid, or less than 7 is acid, greater than 7 is your base. Bases are always more harmful to the eye. We always think acid, our natural reaction is like, oh, acid is bad, but bases are worse. It is very helpful for your staff or whoever answers the phone or you to find out what chemical was in the patient's eye, tell them to bring it in so you can understand what, was it an acid, was it a base? You can look it up and research it, but you will just rinse, test with some of the litmus paper, rinse, test with the litmus paper. And when you see that orangey yellow here, then you can stop the irrigation, but you want to irrigate the heck out of that eye. With that, we are ready for poll question 4. It should be, what is Katie Greiner's favorite thing in the office to use? And it would be litmus paper, but that's not the question. So this one is, which of the following cases may be a candidate for a pressure patch following a large corneal abrasion? Is it a contact lens wearer? B, someone that is scratched with vegetative matter? C, a non-compliant eye rubber with dementia? Or D, when the abrasion has some surrounding corneal infiltrates?
Now,
So we're going to talk about pressure patching because sometimes it's taboo now, but there may be some reasons for it.
Kate, a couple things came in very recently on the chat. Should we consider amniotic membrane for chemical injury and pain? What are your thoughts there?
Yeah, I am and actually I think I'll probably want to go back and edit because I think that is a wonderful option. I'm a big fan of cryopreserved. I do some dehydrated, but I'm a huge fan of using cryopreserved. I think there's a great healing property in that. I guess it would depend on the patient's level of discomfort. I might just really at first get them as comfortable as I can and then take that, the next day, get that membrane on them and watch them closely. If I'm able to do it right away and cover them with antibiotics, yeah, I think that's a great comment. And thank you, whoever said that. I appreciate it.
And I think this involves penetrating injuries. Does a bandage lens help prevent IOP from further decreasing, or are you just applying to make the patient more comfortable?
Yeah, I mean, it would definitely can keep the fluid, in there. And like Joe said, some of these can be self-sealing, which is good that our eye can do that. But ultimately, there's still a problem brewing inside that eye. So a bandage lens is so that we can kind of stop that fluid flow. We actually keep a contour lens. Again, I'm not branding here, but that's just the large diameter soft lenses for like if we have a bleb leak, because the bleb, is up high on the sclera, and so we'll use like a really large 20 some millimeter contour soft lens to stop that leak. So yes, it does stop the leak at least in some part.
Yeah, to answer the question, it's used more for wound flow, sealing the leak. If there's an abrasion there, then the secondary would be to help with the abrasion. But like Katie said, a lot of times you get these wound leaks from these different valves and procedures that they're doing nowadays. And you just throw a bandage contact lens on it just to really kind of seal it up, and then you could take it off so that they don't need stitch, because it's hard to stitch these blebs and these different things that are out there, these different procedures.
Obviously my talk is about pain and I want the patient to be comfortable, but in a situation of penetrating, I'm more worried about the, long-term situation, and getting that leak to stop is really important.
Joe, any more questions?
No, we're really caught up.
Okay, so the result of the poll is we have 12% going with contact lens wear, letter A. We have B at 7%. Your winner at 77% is C, and then D is 4%.
Okay, good. So the answer is most definitely C. A non-compliant eye rubber with dementia is the best candidate of all these for a pressure patch. So, I think I graduated 15 years ago, almost 16 years ago, and we learned how to pressure patch in school. So there's a picture of it there. But bandage contact lenses were definitely becoming more and more of a popular way to treat abrasions. But if something is vegetative in nature, you could just brew lots of infectious agents, like, anything fungal can grow in that situation and blocking the oxygen with a contact lens. Contact lens wearers just have a different flora to their eye. There's just a lot more bacteria risk. So if they're already a contact lens wearer and now they have an abrasion, I would strongly recommend, not not pressure patching them. I don't want more things to brew underneath there. Or if they have early signs of infection, I really don't want to go to a pressure patch on these patients because I just can't monitor that. Everything's a closed, dark system, warm growth areas it's like a petri dish for bacteria. So we really probably don't want to go to that method for those patients. But there's some patients that are non-compliant, they're not coming back to you, or they're in town for a night and they're in extreme pain, and you've ruled out all the other concerning things that I listed. It might be the right case for them. If the patient in our example, they have dementia and they can't stop rubbing their eye, that abrasion's never going to get better unless you treat it with a pressure patch. Or if you just can't get a bandage soft lens in the eye and you really think it warrants some type of coverage, then a pressure patch could be appropriate. You definitely need to use a broad spectrum antibiotic. We'll use like a Cipro ointment or a Polytrim, patch them up, and then we follow them very closely. Like I'm talking next day, so that we can look at that. But there are some cases with this, you guys, that you're just you don't want a bandage lens on them. You don't want a pressure patch. You're just gonna cover them with lubrication, ointments, and lots of tears every hour or so. Which takes us right into recurrent corneal erosion, something very common in your offices. Primary cause is your basement membrane dystrophies, but also if they've had a history of trauma, even if that trauma was years and years ago, they could wake up one morning and dry eyes and open those eyes and cause a recurrent erosion. Things that are vegetative living things tend to be more likely to cause recurrent erosion, scratched by a fingernail or a tree branch. But the common symptoms of pain, tearing, and photophobia right upon awakening. And if you put a drop of anesthesia on them, do they feel better? Yes, that means it's a very superficial injury. And the ways that we treat these patients are, again, your ointments. Sometimes we have to debride that tissue because it's just so loose that it's never going to heal properly. So I am a big fan of getting rid of some of that loose tissue. Using a bandage lens in the appropriate patients. We'll talk about doxycycline and what could a scleral lens fitter say besides giving an option of scleral lenses. I do have some pretty awful EBMD patients that do not want a procedure done, as I list here below, like a superficial keratectomy, and some of that irregular surface I can smooth out with a scleral lens to give them better vision. Anterior stromal puncture, actually, I was curious. I was looking to see if any states allow this in their states. I'm curious if like Oklahoma allows this. So in Ohio, we cannot do anterior stromal puncture. It is not a very commonly performed procedure today, but it actually just involves taking a 26 gauge needle under anesthesia in your chair and actually just in that area of the epithelial dystrophy, or where the recurrent erosion is, just puncturing that area lightly and causing scar tissue. You do not want to do this if it's central axis. So this would only be for peripheral ones because we don't want to cause central scarring or refractive shifts, but patients do heal really well from this. And I do have a few surgeons that will do this occasionally in our clinics. We do this procedure, my surgeons do this procedure much more commonly, a superficial keratectomy. They actually even dressed up as Super K for Halloween with big capes. That was their superhero. And this is where we just have the surgeon remove corneal epithelial tissue down to Bowman's layer, just under topical anesthesia. It's not a major procedure. Some people choose to do it in the OR just because they have better microscopes, but it can be done right in your office. And place a bandage lens for a few days, very similar to how they'd heal from like a PRK surgery. And this would allow that dystrophy, cornea, or recurrent erosions to, regrow healthy. Definitely conditions can come back, but it can give them a significant amount of time where they're more comfortable. And just my kind of PSA to everybody in a cataract world of premium services that we live in is definitely you want to work with surgeons that look at the cornea and will clean up irregular corneas that need that before a good cataract surgery. If they have basement membrane dystrophy and they're going to their plan is to have the best outcome from cataract surgery, we definitely need to be proactive on that before they have their surgery done. That has nothing to do with pain, but I couldn't not mention that tonight.
Actually, Katie, before you go on, I understand what you say about the SK. We have some corneal surgeons that we send for a cataract procedure, and they think that they're going to be a very quick thing. Next thing you know, they have an SK done, and now it's 3 months of healing. And then they have a cataract, and they have the other SK done, and becomes a 6 month procedure. And while it's very effective, I can't think of a single patient that came back to me and said, darn it, I am glad I did that SK. That was great. I really enjoyed that. But really, my clinical
Not
pearl,
wrong. You're not wrong. We do
my
it
my
all the time.
my clinical pearl about recurrent corneal erosions, and this comes from my work as a expert witness in medical malpractice. You use the phrase that we all know that we learned in first grade of optometry school that when you have pain upon wakening, that's recurrent corneal erosion. But I think it's very important to really question the patient. Did you wake up and then immediately feel pain? That's recurrent corneal erosion. Did you have pain that woke you up? That's a corneal infection.
There you go. I love that. That should be on a t-shirt. That makes sense. Yes, very, very much so. That's a huge differential there. That's a huge differential because a recurrent erosion isn't going to wake you up. You're going
Yeah.
to wake up and then feel it.
But superficially, too many optometrists hear pain, wake, and they go
Go
immediately to
there.
recurrent corneal erosion. And what they don't realize is the pain developed because in that warm, moist environment where the lid is not blinking and shearing bacteria off, it's growing, and now you have a lot of pain.
BTK, not a surgery we do as often in our clinic, but this is using an excimer laser to treat the irregular surface. You don't want to overdo this because you are thinning the cornea, but sometimes we can actually couple that with refractive surgery. If there's a small amount of prescription, we can actually treat that at the same time as getting rid of the irregularities. So also an option for these recurrent erosion type patients. Doxycycline, I'm a huge fan of doxycycline, again, in the right patients. We know that the MMP 2s and 9s are an increased concentration in the tear film in these patients that have irregular epithelial tissue, and that causes the stability of the basement membrane to be reduced. And so tetracyclines will inhibit that activity and have shown some effectiveness in patients that have these irregular epithelial tissue. Low doses, like a 50 milligram twice a day or 100 once a day for a couple months, making sure you're not using it in patients that are of childbearing age or pregnancy. It can affect tooth development. Children should not have it for that reason. Can cause some sensitivity. Textbooks would say with dairy products, and obviously they're allergic, but it's pretty tolerable medication for patients. I just always tell them to take it with a little bit of food. And, I live in Ohio, so we don't see the sun very often. So not as concerning as those of you that might live in Florida. Vitamin C is huge, right? It's natural. Maybe you won't get a cold if you take it too, but 1,000 milligrams a day. We oftentimes talk about vitamin C with patients if they undergo one of these types of procedures or like a PRK procedure to help them heal. It suppresses the angiogenic factors. It inhibits your corneal neovascularization issues. It is just, I think, a really wonderful gift of nature. So don't forget the natural stuff like vitamin C. Patients like to talk about what else they can do besides, medications. We talked about corneal foreign bodies. Don't forget to look at the conjunctiva. Joe mentioned, not everything has to penetrate the cornea. It can definitely come in from the side and go through the sclera as well. These can most definitely cause irritation, maybe not as much pain as it would in the cornea, but definitely irritation. And these ones, sometimes you can irrigate them away, you can wipe them out, you can pick them out, but there also can be situations where, it's lacerated or punctured. If you think it's full thickness, which has to be pretty traumatic to become full thickness, then those definitely need referred out. But a lot of times, if it's punctured slightly, partially, you can actually just use antibiotic ointment and watch it closely. And in the bottom one, you'll see an embedded foreign body. That one won't come out. That one is embedded there from a motorcycle accident. It hasn't caused the patient problems, and it'll stay there for years to come.
Hey, Katie, before you get too far, a question on recurrent corneal erosion came in, and I think this is a question that would be pertaining to a lot of people would have. How long do you keep a bandage contact lens on a recurrent corneal erosion case?
I could have many an answer. I think if you polled a bunch of eye doctors, we'd all have different answers. If it's their first one, I'm more likely to remove it in just a handful of days, maybe 3 to 4 days. The way my clinic works is I'm usually in the same office Monday and Friday. So I could even, as long as I'm covering them with an antibiotic, I may even let them go 3, 4 days before I see them again. But if I have someone that is really having issues with this and they're like, I'm not getting that surgery done, I've gone a week at a time. And I've even had it, probably off label, but I've had patients where I've had them, change their own bandage lens. They are so bad that they have we've trained them to change their own bandage lens. And my cornea specialist will do that on the ones that won't move to a Super K right away.
I think the answer too, like you said, would be there's a lot to it. Is that one, if you're using it for pain, you're going to use it for about a week if you're just trying to heal the abrasion. Then it becomes the second part, are you trying to be therapeutic now and stop the recurrent erosion? I think cryopreserved amniotic membranes help in that therapeutic part. If you're trying to go for therapeutics and using it, I think up to 6 weeks, exchanging it about every 2 weeks. And I always say, Joe's a gifted writer. I'm not a gifted writer, but I do a thing for these people that that won't go for these Super Ks or these PRK type of procedures, PTKs. That I have them do a nocturnal bandage contact lens. They tear open at night, so I fit them with a focus night and day. Have them wear it at night. They buy them. They learn how to change them, and I've had people doing it for 2 years. I have about 3 or 4 patients in my practice do it, but I call it a nocturnal bandage contact lens. And I say about writing it up that I've never seen in the literature, but I'm not a big writer. I'd have to have Joe's help on that. But that's a good way of doing it. So it depends on the answer. I think why everyone would be all over the place would be, are you using it for pain or are you using it for the therapeutic purpose?
And your nocturnal ones, do you use an antibiotic prophylactically at all for those patients?
No, because
No.
it's basically once they're healed up. So once they're healed up, they wear it and they take it out in the morning. They get up in the morning, take their shower, kind of get the moisture going. They take it out and put it in the case. They kind of reverse wear it as opposed to wearing it during the day, because they're not going to tear open during the day, most likely. At least the ones I haven't. And then they kind of wear it like a retainer at night for their teeth, or those who had braces. They put it in at night, go to sleep with it. The contact lens takes the brunt, and then they take it out in the morning again before going on their everyday activities. So
Yeah, I definitely think that's worth writing up at some point. And I have those patients as well that I say make sure you're lubricating those a little bit before you go to bed. I think it's nice to add a little hydrating tear. And then, a big topic I have is, you might love a fan, but I don't want that blowing on your eyes at night. I don't want circulating air. And, I've gone to using sleep masks and things for patients as well, just to avoid that, because we all creep our eyes open a little bit in sleep.
And Katie, here's a question. I think it applies to the conjunctival foreign bodies and the abrasions and lacerations. Do you need 10% phenylephrine for the bleeding?
I actually think I put that on here. You can use a Q-tip with phenylephrine if bleeding, so you can stop it. So that's definitely something you can do. I have not had to really use that for very long in our clinics. I haven't had any with that situation. But yes, that's definitely something you can do. The first picture up here is a tick. I didn't even mention that. So ticks can live anywhere. So this was not a good one up there at the top.
And always remember about bleeding. Don't worry too much about bleeding in the conjunctiva. All bleeding will eventually stop.
A good tip for a parent too, right? All bleeding will stop.
Eventually.
Eventually. Uh, Corneal foreign bodies. We talked a lot about these already. Get them out. I love a needle. I am not a fan of spuds. I just think I'm digging too much. A needle can pop it right out. Try to get right around that rest ring and get it all out. Algae brushes are okay. I think sometimes they make a bigger mess. So if you can just use a needle, I think that's just the easiest, cleanest way to get it out. And treat these just like a corneal abrasion. And again, always look for that puncture full thickness. All right, let's move on a little bit to a different topic here, infections. Most definitely those can cause pain. Some of them will wake you up. As a survivor of EKC, I will tell you, I actually think it truly was painful. Your viral conjunctivitis is just more uncomfortable, but EKC, once you start getting these pseudomembranes and subepi infiltrates, you can become pretty uncomfortable. These eyes are pink in nature, not always red. I am a huge fan of peeling membranes because when I had mine looked just like that bottom picture there. I went in every day and had the doctors for a week peel off membranes from me, and I did not like it during it, but the relief that it brought afterwards was amazing. And here's a blood comment. They can have bloody tears. I tell my patients, if you see a little blood on your tissue, pink on your tissue, that's okay. It's because we had to peel away these membranes. Betadine washes, those have become more and more popular over the years for EKC as well. When I see subepithelial infiltrates, steroids make patients feel much more comfortable. Some of our immunomodulators are really helpful. When I had EKC, and I definitely got it from a string of fraternity boys that spread it around their house, they all came to see me, and I did all my gloving and washing and everything, but I ended up with it. I threw the gamut on myself. I was using like Lasticaft and Lotamax, and I was using NSAID drops. I mean, I had it all going on and peeling all the membranes. So definitely, I would say EKC can be very painful for your patients. We can't forget about herpes simplex. This is very commonly held in our system, over 60%. I think it's even way higher than that. We carry the virus within us. This can show up as follicular reaction, vesicles, as you can see on the photo here, SPK, dendritic lesions that will stain, especially with rose Bengal, which we do try to keep in our clinics in at least a small quantity, usually unilateral in nature unless someone's immunocompromised. I've seen it in, unfortunately, some very sick cancer patients in both eyes, and has a decent recurrence rate occurring, according to the HEAD study, 18%. And stromal, it can be even more aggressive. So here's our picture of the classic dendrite there. Many ways you can manage it. You can do Zergan, which is a wonderful drop, but sometimes, or gel, sometimes a little more difficult to find or more costly. Trifluoridine's been around for a long time, but you got to use it 9 times a day. Lubricate the heck out of these patients. Oral antivirals can also be used. So remember, there's multiple oral antivirals that are pretty inexpensive for our patients. You don't need both. You could do one or the other, but you definitely need to lubricate these eyes. Of course, I'm going to tell you, I have quite a few patients that have survived their HSV corneal issues, but they ended up with significantly irregular astigmatism that needed some kind of help, like a specialty scleral type lens. And these patients, unfortunately, can turn into your neurotrophic keratitis patients that I've seen, definitely needing more of like an oxervate type treatment to deal with later on problems or sequela from their corneal infection. Corneal transplants in a worst case scenario. And then our other form of herpes here, zoster, HCO, classic sign from boards, Hutchinson sign, where you see the vesicles on the tip of the nose, can follow nasociliary and be found in the eyes. This one, you'll have pseudodendrites, so they do not stain like your cousin does. They could have SPK infiltrates. They're light sensitive. They're uncomfortable. They could definitely tell you that they're in pain. Lubricate, lubricate, lubricate. I prescribe just a bland ointment or tell them to put Vaseline on their vesicles that might be on the skin. And steroid is okay in these patients and oftentimes brings them comfort. And you can prescribe double your dose in zoster of your oral medications. That's kind of an easy rule of thumb. And unfortunately, these can also end with irregular surfaces that may even lead to corneal transplantation. And you can get recurrence of the virus in there. So here's your pictures of, again, following your midline, seeing those vesicles, and not the best of pictures of a pseudodendrite, but they do not stain. Bacterial infections, we all know these are horrible. These definitely will wake you up, leads to, I haven't seen too many infections that look like this that end up okay. These eyes usually end up very scarred, leading to, again, fitting a specialty contact lens or going to a transplant, especially those contact lens wearers. Contact lens infections, Pseudomonas, it's awful. It will eat right through that cornea. These are really closely monitored, often referred to cornea specialist type conditions, and these patients are very uncomfortable and in pain. Broad spectrum antibiotics, culturing is so crucial for these patients if they're not getting better after a day or two. Fortified antibiotics are oftentimes needed, using every 30 minutes around the clock. These are really tough cases, and these patients are very, very much in pain. And then there's our non-infectious keratitis. One example is filamentary keratitis. I do enjoy taking filaments off the eyes and giving patients relief. They are uncomfortable. They have foreign body sensation. This can be caused because of past trauma and healing issues, if they're really dry or neurotrophic. I've seen it in patients that overwear their contact lenses or in SLK situations. It's really wonderful to debride these using either a wet sterile Q-tip or some forceps. I have definitely in these used bandage lenses to stop the formation of further filaments, to kind of break the cycle. So in those cases, I may use them for several weeks at a time. You can get mucomist compounded for the patients that they can use, and acetylcysteine, sometimes a little more difficult to come across. Here, I did mention it, you guys, I have amniotic membranes in here. I can't do disservice to amniotic membranes. I've been able to use those for patients that keep getting continuous filaments. And in our clinic, our surgeons sometimes will even have to do temporary tarsorrhaphy just to help heal the surface once and for all. They'll use a glue, just a glue from Home Depot, super glue will do that temporary tarsorrhaphy for them. And don't forget any type of irritation and keratitis that can be caused just from dry eye, right? How many patients do we have a day in our chair that have dry eye and consider that painful? I was just reading through a bunch of different studies. I found that this one was interesting. It was 1,600 females that had been already diagnosed by an eye doctor with dry eye, and they were using tears and had dry eye symptoms for at least 3 months. So in this study, they tested these just on their forearm using a heat stimulus to see how sensitive and tolerant these people were of pain. And a majority of the participants had both high sensitivity and low tolerance to pain. So this is showing us that our patients with dry eye are very sensitive patients. And then I looked at this and said, well, what if we did this study in males? Would it be even higher? I don't know. It was all females. Females had a problem with it. Our male counterparts, I don't know. Dry eye feels like so many things, you guys, right? This list, painful is one of them, but your patients can present with this whole list of things. So we really have to ask questions about their symptoms to try to get to the bottom of what's causing the problem. And lid disease can cause this too. So we talked about earlier on, I said, look at the whole patient, look at their eyelids if they're in pain. If they have an ulcerative blepharitis, that can be really uncomfortable. There's hard crusts and matter, and it can ulcerate, and you can peel those off, and there can be bleeding to the eyelids. So even things like meibomian glands being blocked, we know those can turn into styes and cause pain. So we might not always associate lid disease with pain, but it most definitely can be. And so as we kind of close out more of the first part of the talk with the superficial type issues, I just want to say our goal for the doctor and patient is, as Greg mentioned, in these acute situations that I listed, is to resolve the pain and the discomfort. The one that's not that I would put dry eye as more of a chronic, obviously pain, chronic irritation, but everything else here we could get them to a zero by treating them appropriately. And make sure you change the course. I'm guessing Joe talking about being an expert witness. If you keep doing the same thing and not getting the results, that's not the right path. You need to be watching these patients and say, if that didn't work for you, we need to pivot and try something else. And then if that's not working, we have so many wonderful colleagues. Refer to a fellow optometrist, refer to a specialist. We have these patients that we don't want them to have chronic issues. We want to stop the pain in its tracks and make them better. But if it does become chronic pain, you may just gain that patient for life. All right. We have about 30-ish minutes left, so we are going to move on to some more advanced topics here and pulling from what my Milli Vanilli days, blame it on the pain. Yeah. So we're going to talk about ocular pain and some treatment options in these following conditions: iritis, scleritis, closed angle glaucoma, sinusitis, and optic neuritis. Remember, these ones may need specialists, as part of the patient's, path of care. There might need to be integrated care there. So now we're going to look at the left side of our chart. And as we go down the list, we're not staining. Now we're looking at elevated IOP. If it's elevated, we're going to start thinking at the pain level of an angle closure glaucoma. If it's not elevated IOP, but their vision is decreased, then we're going to go this way. And then we're going to say, okay, their vision's decreased. Do they have photophobia? Yes, maybe that could be an anterior uveitis or keratitis. Do they not have photophobia, but they have, maybe let's ask about hyperemia? Yes, hyperemia. Maybe a scleritis here. No hyperemia. Maybe an optic neuritis. So we're going to follow that pathway for the rest of this talk and go through those conditions. Anterior uveitis comes in many flavors: acute, chronic, which chronic, some of those patients, you've probably seen them, they know something's wrong, but they're not in that, urgent pain situation. They're kind of like, oh, I think I'm flaring again, but it's old hat. This happens to me quite often. I never like post-operative pain. That is not normal when we're talking about like a standard cataract surgery. You need to start thinking of something more serious, maybe even like an endophthalmitis. Usually when they have a rebound iritis, they're more photophobic and irritated, but not pain. And then obviously traumatic will cause discomfort and pain, and that could be a form of uveitis that's come up. Hallmark is cell and flare, AC, and I don't know, they say that your circumlimbal perilimbal redness is key, but usually I just feel like in most of these cases the whole eye looks injected. Pain, photophobia. Photophobia is huge. Red eye. All right, let's talk polling question. What is the most common reason for an anterior uveitis? Is it A, idiopathic, B, HLA-B27, C, Lyme disease, or D, rheumatoid arthritis? This is our second to last polling question, so let's see what you guys got.
Polling question is launched and we have people responding to it. Joe, are there any questions or any more comments from the audience?
No questions, but you got a couple of comments giving you props for the discussion on the nocturnal bandage contact lens.
Perfect. All right, Joe, we're gonna have to knuckle down and write something up. So we have to
Yep,
lean
you
on
are. You said it. We got it recorded.
Got it recorded. The other point I want to point out, you just said about that perilimbal flush. Yep, I see it a lot with uveitis, but also those contact lens overwears, right? There's people that just abuse it and sleep in it, and they come in and they take it off. You can see that that limbal emphasis, as I like to say.
Emphasis. I like that. I'll see that in a poorly fitting scleral lens too. It's too tight.
Well, there you go. A little scleral bonus action there. So while the polling question is in, it looks like, it looks like people are good here. Let me display it. And we have 66% going idiopathic. We've got 12% saying HLA-B27, Lyme disease 2%, rheumatoid arthritis at 22%. So your winner is A, idiopathic.
Good. You guys are still with it this late at night. Yeah, idiopathic. The other ones can certainly all cause uveitis, but the most common reason is idiopathic. And we'll talk through when it's not idiopathic anymore. There's that red ring up here, so we can see that on an anterior uveitis, inflammation of your anterior chamber. There's actually 3 forms of anterior uveitis. It's broken down into iritis, anterior cyclitis, and iridocyclitis, although usually they're just lumped into anterior uveitis. Most of the times you're not really breaking down that definition because you're going to be treating them the same way. But the most common form of uveitis, hands down, is anterior versus posterior. But idiopathic, number 1, followed by HLA-B27 being the second most common reason. And uveitis can be really detrimental to our patients. 10% of legal blindness issues from uveitis, that can result in, scar tissue, synechia, and 30,000 new cases a year that go blind from this. So we've got to be on it. Why do these patients have so much pain and discomfort? We think that there's an irritation of their ciliary nerves, and the ciliary muscle will spasm. They'll have light sensitivity. We're going back to that trigeminal nerve from the ciliary spasms. And pain in these patients will be, a dull, an ache, a throb, or a radiating pain. And in this patient, they have so many cells that they're actually starting to layer there in the anterior chamber. So it's typically considered idiopathic on their first episode if it meets certain criteria. It's unilateral. They do not have any known autoimmune conditions. It's non-granulomatous. Their presentation may be mild. And these patients you're going to treat with your topical steroids. I do really enjoy a Durezol because they don't have to use it as often. So, instead of dosing every couple hours, this one I could dose, 4 times a day and really get the job done. Cycloplegics for comfort, to stop the movement of the iris. And you're monitoring them pretty closely to watch that the cell and flare is decreasing, they're feeling better, and that you can slowly taper the steroid. You don't want to have a simmering fire and have that blow back up on you. So you definitely want to taper on these patients. But I would be concerned of not calling it idiopathic if they, have repeat occurrences, if we see it in both eyes, if there's a granulomatous look, if, they are telling you that they have joint aches and pains, if it's more of an aggressive presentation. So we definitely need to be on the lookout for that. Idiopathic is the last thing on your list. You need to rule out the concerning stuff until you land on idiopathic. So on these recurrent or more aggressive issues of UV or cases of uveitis, you're going to see there's a long list of things that you can test for, oftentimes in lab work. And as ODs, I encourage you to, order your lab work yourself or work closely with the patient's family doctor to do so. But we are very capable of having a standard uveitis lab list that we send along with the patient. We just have one that we can print out in the office. We check off what we want done. We put our fax or cell on there, and we get the results back pretty quickly. So here I listed for your reference, many of the common tests that we can run for these patients. Some could be a little more aggressive, like you need them to get a chest x-ray in like a sarcoid patient. Maybe that's step 2. We'd start with your standard common lab tests that are listed here on the right. IOP can be all over the place in anterior uveitis, so typically it tends to go low because of ciliary shutdown, which means that we're reducing the aqueous that's secreted. But in some cases, like your herpetic, your lens-induced, your Posner-Schlossmans, your Fuchs heterochromic conditions, in some of those cases, you actually can have higher IOP, and in those cases, we need to monitor that and help lower the patient's pressure. Definitely, if it's related to systemic issues, their eye can get better temporarily, but if they're not controlled from a rheumatological standpoint or infectious standpoint, then they'll continue to have probably recurrent issues with this. So it's most important here to work very closely with the team approach for these patients. And, I said there are many cases of blindness from this condition, and look at all the list of reasons. They can get macular edema, neuropathy of the nerve, scarring in the retina, posterior and anterior synechia. I mean, all these things can happen with uveitis. And I feel like when I have students at first, they either think it's so easy and they just throw a steroid on it, or they think it's like the end of the world and they have to run every lab test. So there is definitely a middle ground, but we need to, watch these patients closely and make sure that obviously they do not progress to these severe complications. I had to throw in posterior uveitis just to make sure I felt like we were complete this evening, but really with these, you're not always going to You're really almost never going to get pain sensation with this. These patients, if it's just posterior uveitis, they're going to be the ones that come in with decreased vision, blur, floaters. If they have an anterior uveitis and also a posterior uveitis, then they'll be uncomfortable. But a posterior uveitis would be a choroiditis, and that can be caused by some pretty severe things like infections, autoimmunes, parasites, an endogenous endophthalmitis. That's really bad. You can lose your eye very quickly with that. Tumor growth, many are reasons for a posterior uveitis. All right, we're going to move on to scleritis as we get closer to the, yeah.
Hey, Katie, let me, one of my favorite things, and Joe's been hearing me say this at a lot of lectures when we talk about uveitis, is that it's not often talked about, but there's certain parts of the body that are immunoprivileged. And that means that, like, for example, if I go to a strange area, like I was just in Poland and I ate Polish food, and I was in Lisbon and I ate Portuguese food. And these are strange areas. And when I eat it, my body didn't have an immune system. So really from my mouth, through my intestines and my stomach, it's immunoprivileged. That means limited or tightly regulated immune system. It kind of protects those areas from that kind of full force of that immune system. The inside of our eye is immunoprivileged, the anterior chamber and the retina. So anytime, my point in going into all of that kind of rambling is that anytime that you see a uveitis, think that immunoprivilege has been broken. Why is there an immune system inside the anterior chamber? Even if you put something in there that could be a pathogen, the immune system's really not there to recognize it. Okay. Once you have that cell and flare in there and you see the white blood cells, immunoprivilege has been broken for some reason. So that's why it's usually you have to go aggressive with the treatment because the eye typically cannot regulate. So that's why you're usually using atropines and steroids because again, it's kind of protected. So the brain is the same way, the testes, the placenta, and our GI system, they're immunoprivileged. And the one final clinical note, they think that's sometimes why a choroidal tumor, whenever it learns that immunoprivilege, can then move throughout the body pretty easily and metastasize because it learned that immunoprivilege. That's one of the thoughts out there. It learns that immunoprivilege.
Interesting.
That's
So,
it.
Greg, does that fall under some of your functional studies? Is that something that you look at closely there?
No, no, it's just part, not no, this is it can be functional or allopathic in a sense. Allopathic meaning opposites cure. It's just that immunoprivilege. Like again, if I eat a food, it doesn't like I eat something strange, my body's not going to have an immune reaction to it because I'm eating it. Luckily our immune system or our digestive system is like that. So it's well known, it's just not talked about. But the eye is immunoprivileged. So when you see an inflammation, like you should be able to put something into the anterior chamber. If you could get it in there, there's no immune system in there. That's the immunoprivilege of it. When your eye is reacting to a uveitis, that immunoprivilege has been broken and your immune system is in there.
Yep. Okay. I like that.
Just,
Thank
just,
you.
just FYI. So it's not talked about a lot. So,
No, I don't think
um,
it is.
yeah, so people can look up immunoprivilege. It's pretty cool, but you'll see that the inside of the eye, the retina, and sometimes the cornea, it kind of goes back and forth, and that's why everyone says, "Oh, the cornea, you can do a corneal transplant because there's no blood vessels." Well, the immune system can still find it, right?
Yeah.
But that's why they think corneal transplants work too, because it's most likely immunoprivileged. But the anterior chamber is, and the retina is.
I think that's some good light reading after tonight. Everyone can look up that as they
Yeah,
go
it's
to
kind
bed.
of cool. Yeah, it's kind of cool.
It
Look, the
is. I
audience
think
can Google it, look it up. It's good stuff to read about.
scleritis. Classic symptoms of scleritis. Scleritis is definitely in the pain category. Boring and even severe pain radiating into jaw, forehead, brow line. I think sometimes when mild cases of scleritis present, you look at the eye and think, gosh, is it that bad? And they're in pretty good pain. They're pointing to the, frowny face, maybe with a tear on your scale. And then gradually that eye gets more red, pain on eye movement can develop, swelling, photophobia. These can progress to decreased acuity, double vision. So these ones can become pretty severe. You can have sectoral or diffuse inflammation, and this gets into those deep scleral vessels. Here's a phenyl phenylephrine question again. So when you put that on the eye, it will not blanch with phenylephrine because this is that deeper layer of vasculature. And this affects 4 out of 100,000 people, and 50% of the cases will typically have an autoimmune disorder that's uncovered at some point. We can classify scleritis into several categories: your diffuse anterior, your anterior nodular, your anterior necrotizing in 2 forms, with inflammation or without inflammation. Without inflammation is your scleromalacia perforans, which usually is not at all painful, although it looks awful. And then the anterior form is by far the majority. I think 98% of cases are anterior, 2% are posterior scleritis. And again, no vessel blanching with that easy in-office 2.5% topical phenylephrine. Here is a picture of your diffuse anterior scleritis, again, being your most common, very benign in nature, but red and swollen, and it can progress into issues with a trabeculitis and maybe even a secondary IOP spike. Responds pretty well to your oral NSAIDs. I know we're always tempted with the red eye to throw steroid drops on it, but these patients just don't respond well. I still think it's in our nature that we do it. I see that all the time, but oral NSAIDs, most of these just over the counter, but at a higher dose than you would normally take them, or prescribing indomethacin for patients as well. In your nodular form, you can see a picture here of that, more localized inflammation, a tender nodule, painful as well, deep red, could have multiple of them, could have one of them. That conjunctiva will become very congested, as you can see, and they could also have an episcleritis present with this. And these patients also respond well to an oral NSAID. Necrotizing scleritis, very destructive to the eye, just as the name implies, very threatening to vision, more common in females, definitely more common in systemic inflammatory conditions. These patients can actually be in true excruciating pain, and they can have areas of intense vasculitis that can actually expose, you can get so necrosed that it can expose the choroid, and the inflammation then can continue to spread across the surface of the eye, into the cornea, into the ciliary body, causing a uveitis, into the meshwork, causing high IOP. These ones are very severe cases. And then here is your scleromalacia perforans, which is rare, and it is typically very asymptomatic. It just looks really bad, and obviously could be, it is very detrimental to the eye. The sclera will become thin and marbled looking. You'll start to see the choroid very much exposed here. Staphylomas can form, and these patients also have a very long history of systemic and inflammatory disease. And then posterior scleritis, which I said is very low percent of the patients, will have this scleral inflammation posterior to the rectus muscle. And this one on a B scan will show what's commonly called a T sign. So if you can see that outlined here, this is where they have an increased thickness to the eye wall greater than 2 millimeters. And this is the fluid that forms in the Tenon's capsule to create the T sign that's actually pathognomonic for posterior scleritis. And then this could get so bad that it actually progresses to a serous retinal detachment. These patients are the ones that are getting diplopia and loss of vision, and often have an anterior scleritis associated with it. So these patients most definitely are, as we said, at least 50% of them have some form of autoimmune condition. Lab work is so important for them. A lot of the same labs here that you've seen already for anterior uveitis would also be used for your scleritis workups. We're looking at an ANCA marker, which definitely can be one of our more serious ones in a vasculitis. That is definitely a more concerning prognosis, but also going to, like the chest x-rays or CTs for things like sarcoid. Don't forget, getting workups for just general inflammation as well, like your CRPs and your ESRs. So here in scleritis, 50% are those associated diseases. You actually can have some idiopathic cases in this. 4 to 10% will be infectious in nature, like your TB, your syphilis, Lyme. Those ones, if we're infectious, we don't want to run and treat with a steroid treatment, because that actually can make infection grow and infection worse. As I mentioned, we all want to throw topical steroids at red eyes, but they're not effective in these. The NSAIDs, the oral NSAIDs are definitely the way to go for these patients, but remember those can cause significant stomach problems like ulcers. So you want to talk to your patients about that. And, you could recommend the purple pill having a histamine receptor antagonist or a proton pump inhibitor to calm any of that stomach upset. For these really bad cases, you're not going to hold on to these patients with necrotizing. I think you see that in your chair and it needs to go. These posterior cases, these patients definitely need referred out for oral steroids. They can be given oral prednisone at 1 milligram per kilogram. Or other immunosuppressive agents in addition to that, like your methotrexates. And then they're on a pretty long tapering schedule, as you can see listed here, if they're improving. If they're not improving, they'll stay on that same dose for even longer. So they will go down by 10 milligrams each week. As they go from 80, then they're on their 60 to 40, and then they'll go down by 5 after that as they go from 40 to 20, and then they taper even smaller at the 2.5. So you can see that is just such a long and slow taper of steroids, so much so that this can go on for months and even a year because this is such a detrimental issue.
Let me make a couple clinical pearls here on scleritis. Well, probably one of the best things that you can do for a scleritis is just send them to the rheumatologist. Just like we know a macular on detachment, we get to the retina doc. These CRAOs that come in, we get them to like a stroke ready hospital. Now, probably the best thing I've learned with scleritis, I work right down the road from a 6-man woman rheumatology practice, which has been great over the years. I work closely with them. I've learned a lot about rheumatological disease. They will actually take the patient that day or the next day if I see a scleritis and start to work them up because it's probably something systemic. So the best clinical pearl I could tell you about scleritis, Katie's right. All the topicals not going to touch it. You're going to need some type of orals, but I usually don't start the orals, and that's why they'll see them because they'll do the blood work to try and figure out the systemic underlying cause for this. On the slide that she has up here, necrotizing anterior scleritis, we don't see that a lot now because all the different biologics. So back in the day when there was just a few things out there for these rheumatological conditions and not these biologics like Humira, Remicade, and all these Dupixents that are out there, you could see this immune system kick in. But my point would be if you're seeing necrotizing or this type of scleritis, the patient's probably not going to be around much longer than a year because it's just taking over the whole body and destroying all that collagen and elastin. They're sad cases. So you want to try and keep them seeing, but probably death will overtake the blindness from them. So
having that close relationship with a rheumatologist is so important. Endocrinologist, rheumatologist, I like to make sure that I've got a few specialists in my back pocket that I, have this easy relationship with. And, simply going into their office at some point and just introducing yourself and saying, hey, I'm here, I can help you. If you have patients, that you're managing and you're worried about their eye, I've got you. And then likewise, I can send them back. So I think getting on a first name basis with those people, grabbing their cell phone number and having that relationship like Greg has is really important when these cases come into your office. Angle closure glaucoma. So also having a good relationship either with your surgeon or in the states that you can do emergency PIs, really great for those states that can help now treat these patients. We're hoping for that in Ohio sometime soon. But angle closure glaucoma affects 23 million people worldwide and 50% of the glaucoma related blindness. We all know that this is extremely aggressive in nature, much more so than your standard open angle glaucomas. These patients will have typically steamy corneas. They're nauseous, they're vomiting, their eyes red, they're in extreme pain, their pressure's high, their pupil can be sluggish or mid-dilated, they can have a shallow chamber and injection here. More common in females, older age, Asian ancestry, maybe a genetic component, narrow angles, hyperopia, small corneas, anterior position of their lens, lots of risk factors for angle closure glaucoma. Two major reasons for that, all coming down to anatomy, 90% with pupillary block, as you can see in the top photo, and the rest of them for a plateau iris, which is your bottom photo where the ciliary body is actually rotated and displaces that iris into the trabecular meshwork. So anatomically, there's a couple of reasons for that, but really when they're in your chair, you've just got to figure out what to do with them. You can also have secondary angle closure glaucoma for many reasons. They could have neovascularization of their angle, a horrible phacomorphic glaucoma, posterior scleritis can cause this, ROP, pharmacologic reasons like your iris dilators, your antidepressants, your Benadryls, your Xanax, incontinence medication. So there's a whole list. I mean, how often do you guys get patients call and say, hey, I saw on this ad or I read on the box that I can't use this if I have glaucoma, and usually it's angle closure. That's much more common of an issue than just a standard, open angle glaucoma. But I get those calls on the regular with medications. All right, in our last few minutes here, Greg, we are going to go into one that I think is always interesting. So poll question 6, which I'm ending on probably the hardest one, but which of the following is not a treatment for topiramate associated angle closure glaucoma, or Topamax? Is it not treated with IOP lowering medications, B, a peripheral iridotomy, C, cycloplegics, or D, topical steroid?
Okay, that polling question is open. Joe, are there any comments?
Nope, we're all caught up.
People are probably winding down. I hid upstairs away from my kids, and they're still being wonderful and quiet, hoping they're just sound asleep. Because I even put notes on the door, do not disturb mom. So I'm really happy we made it this far without a 8-year-old busting through the door.
There's still time.
Still time.
All right, we have people rolling in. I'm gonna give it about another 10 seconds here. So, which of the following is not a treatment for topiramate-associated angle closure glaucoma? IOP lowering medications, peripheral iridotomy, cycloplegics, topical steroids. All right, so based upon what I see here, you're going to have to explain this one a little bit, because I'll display the answers. We got IOP lowering medications, 2%. We got peripheral iridotomy at 16, cycloplegics at 45. That's your winner, and topical steroids at 37. So,
All right. I said I ended on a doozy. Let's show you guys this one.
All right.
Topamax. All right, very common medication that we see out there, and actually what Topamax can do to patients, and it can, do it just to, it's definitely a listed side effect, but it's not a always complication of the medication, that it causes swelling of the ciliary body in the lens, which then causes this anterior rotation of the lens and iris diaphragm. So this will cause angle closure, sometimes even bilateral. The cases I've seen in our clinic have unfortunately always been bilateral. It can result in a uveitis. These patients can have these crazy myopic shifts. My most recent patient with this had like a 5 diopter myopic shift. It was nuts. These patients need to immediately stop the medication. We have to do all these things I'm listing. We have to lower their IOP with drops. We need to typically cycloplege them to get them comfortable. We add topical steroids. In some cases, they might even need an IV of mannitol to lower pressure. But a PI will actually not work for these patients because this is not pupillary block. Again, it's that anterior rotation and swelling that's happened at the ciliary body and the lens. And it takes about a week to resolve. I do watch the patient very, very closely, but it's pretty amazing that they just go back to their normal prescription and their normal eye appearance, but obviously they are not a patient that should be using Topamax anymore. So I think that's just an interesting one, and one that you really should just keep in your mind. It is so crucial for our patients to check out their med list, and if something isn't adding up, to make sure you're asking. Sometimes they forget to mention a medication or two, and this is an important one to keep a watch out for.
Yeah, Kate, a lot of people are don't understand the mechanism. And there are a lot of people out there walking around with holes in their iris that they didn't even
Need to be
need.
there.
I just had a patient about couple weeks ago. One of my longstanding patients, he had it wasn't exactly this. It was a very similar mechanism. He underwent a glaucoma surgical procedure. He was on steroids already, and he developed ciliary block glaucoma, malignant glaucoma. His pressure went to 51. I sent Greg a picture of the anterior chamber, which was the iris laying against the cornea.
Oh my
So
goodness.
so his pressure was 51, and you need the cycloplegic. I atropenized them. I just restarted his glaucoma medicines. He's already on a steroid, Durezol, which is as good as it's going to get. By the next morning, he was down to 12.
Yeah. I mean, it seems so counterintuitive, right, on a cycloplegic, but in
Hmm.
these, that is the best, one of the best things you can do for them. But it does. Your optometry brain says that's all wrong, but in these cases, it's all right. And I'm sure, Joe, that these lasers have been done by our ophthalmology counterparts that also did not understand this mechanism of action that's happening with Topamax side effects.
It's what
I
separates doctors from technicians.
Yeah, I think probably the clinical pearls on this to think about with the Topamax is that it's an allergic reaction in my mind to the ciliary body. It usually creates a myopic shift because that lens rotates forward, and the anterior chamber is shallow the whole way across, just not kind of in the periphery where you don't get that lens to iris diaphragm seal. The ciliary body swells, and then that's what causes the whole anti rotation
Everything
forward,
comes forward.
it causes that anterior chamber. So it looks different if you look at it than angle closure.
How much of a shift have you guys seen? Is five seemed pretty aggressive.
Yeah,
Oh,
that's
I've
pretty
seen,
standard.
yeah, I've
Yeah,
seen 5 and 6. Yeah.
5 and 6. Yeah, that was about where we've seen. So in your typical angle closure glaucoma, we want to lower the IOP with some fast acting drops like your beta blockers, CAIs, alpha agonists. Sometimes we need to go to orals, like your Diamox of the world, pilocarpine in most situations, so that we can, pull that pupil in, make it smaller and set them up for the peripheral iridotomy that's coming. And then we can use steroids if their cornea is pretty steamy. But a PI is the standard treatment for these patients as soon as you can get that done, creating another outflow pathway for the aqueous to flow through so you can relieve that pressure. And in most cases, the patient will need the other eye done. Our surgeons tend to look at it and just say, I'm going to do both because I know that, there's a 50% chance your other eye is going to need it if it's not there yet. And these patients need to be followed closely. And if there is a cataract at play, great idea to get the cataract out, because then we don't have to worry about angle closure like we would in a phakic patient. Sinusitis we can talk about very quickly, and we'll close on optic neuritis because we only have just a couple minutes left. But we all know sinus pain is real, and it's all, our sinuses are all encompassing around our orbit. And so, always think about that for your patients as well if they are feeling just that pressure pain. But don't forget that there are things like orbital cellulitis that have pain on eye movement, and that can be an orbital cellulitis, or a preseptal can come from a sinusitis that's gone awry. So I think we always need to keep those in our mind as painful and scary conditions. But just your general sinusitis, you're working closely with their primary care. If they have an ENT, we talk to patients about Flonase all the time. It relieves so much pressure, but we do have to make sure our patients are aware that that is a steroid. And nothing wrong with a good old neti pot. I used that through pregnancy when I wasn't allowed to take all the medications, and that really can relieve a lot of pressure on a more natural way. All right, you guys, I'm going to breeze through optic neuritis so we can get you out on time tonight. But optic neuritis is very much a concern for patients, and they will come in with pain. It's inflammation of your optic nerve, most commonly caused by something like a demyelinating disease such as MS. Remember the retrobulbar location of it, where you won't always see disc edema. The patient's not seeing well. You're not seeing anything concerning inside the eye. We have to think if they have pain, especially with eye movement, that there could be something like an optic neuritis. And that is coming from this tractional force when they move the eyes against that nerve sheath that's inflamed. An APD would be a common finding because this is affecting the nerve. That mildly decreased acuity, they can show a scotoma, red lens desaturation test to test that the affected eye has less redness noticed, just looking at the cap of the, dilating drops. There's definitely some atypical forms of optic neuritis caused by infections. We could do a whole other talk on the other diseases like NMO or Devix, but getting these MRIs looking for white matter in your patients. There are also all the same blood tests that we talked about if we're looking for like syphilis, sarcoid, TB, etc. I call it the scarlet desaturation test because I'm from Ohio, so I just have to throw that in there. That's what we call it in our office. But making sure that you understand that test, that the affected eye will have a more faded look to it, and that's because the red color vision that we view comes from those long wavelength cones in the retina, and that transmission then to the optic nerve is just a sensitivity of the nerve to red. So that's why it's not the blue or the maze desaturation test. It's the scarlet desaturation test. Make sure you refamiliarize yourself as you look at Google tonight with the optic neuritis treatment trial. Lots of important findings out of those, especially that, some of these, the thoughts of using steroid, as you can see here, were no more effective of doing IV steroid than oral prednisone or placebo. So not as positive findings as we thought on steroid use. And I'm right at time, so I think as an Ohio girl, I will end with my dad teaching me as my dad here as a major Browns fan that he passed along to me and then to my oldest son. And there's nothing more painful, you guys, than football season in Northeast Ohio, but I keep coming back for more. So here is my email for any further questions or queries, or if you just want to say hi, please write that down and feel free to reach out to me anytime. And again, I can't thank you guys enough for hanging out with me this evening. And I think Greg and Joe have some housekeeping for you.
Yeah, thank you so much, Kay. That was fantastic. It was really kind of encompassing, soup to nuts. It was really very, very educational. And just as a side note, have you ever seen the movie Draft Day?
Draft day, yes.
I thought you'd like that movie.
Yep.
So I agree, Katie, very comprehensive. Thank you for doing it. I just want the audience to know that that little red circle appeared about 3 minutes ago. It's right there. That's the survey that you can take. If you click on that, then you won't have to wait till 10 o'clock Eastern to get that post-event survey. With that said, this is Pain, Go Away, a review of anterior and posterior eye pain issues. Joe, are there any final questions or comments for Katie?
No, there are not. Everybody is just giving their virtual round of applause.
Well, thank you, everybody.
Fantastic. I can see why after listening to it. With that said, that will conclude the Optometric Education Consultants National Webinar Series for tonight. Thank you for attending. Katie, thanks for a wonderful job.